Okay. The next debate is entitled POCUS is a Problem, Point of Care Ultrasound. Let me tell you a little bit about these two gentlemen. So Maxime Valois is from Montreal. He's an emergency physician and an intensive care physician. J. Christian Fox, or as we call him, Chris, is from California. He practices at UC Irvine. As a way of getting to know the speakers, I asked them some random dichotomous questions. You know, do you like chocolate or vanilla? Do you like salty or sweet? And these two gentlemen are about as diametrically as opposed as you could imagine. Maxime is a dark chocolate guy. Chris Fox is a milk chocolate guy. In terms of colors, Maxime likes black. Chris, he's a water guy. He's a big sailor. He likes turquoise. Let me give it up. Let me have you give it up as we introduce our next set of prize fighters, Maxime Valois and Chris Fox.
I'll take it.
Good luck.
So, the fox, I'll call him the fox if you don't mind. The fox and his ultrasound fanatics seems to think that I'm a fraud, an heretic, and that my work should actually be indexed just because what I'm saying, point of care ultrasound is a problem, kind of contradicts with who I am. I did co-create EGLS with my friend Jean-François, and I am one of these sono evangelists going around the world, crossing seas to teach ultrasound. So I think that's the first thing I have to clear up before I even talk about point of care ultrasound. And to do that, I need you to allow me to do a small, albeit 90-degree detour before I actually talk about ultrasound. And I will need your help. So stop trying to hook up on the Wi-Fi and stop tweeting for a second. Since the 1800s, temperatures have steadily risen. And the last 18 months have been the warmest ever recorded in the history of the archives we have. Ice caps are way more melted than they normally are. So now I said I need your help. So I would like everyone in this room to stand up right now if you believe in global warming. I was kind of hoping someone would stand up. We know part of the problem is due to the incredible amount of car pollution there is out there. So I'd ask everyone who actually owns a car or drives a car, even occasionally, or has a driver's license, to sit back down. Wow, that's almost everyone. Almost everyone stood up and then sat back down. The others, you have to stand up all my talk. So you see, even if I am part of the ultrasound faculty here at SMAC, I'm not a fraud, and I can believe that there is a problem with point-of-care ultrasound. We'll first start by seeing the impact of this revolution in our everyday practice, then cover how faster knowledge translation times can actually give their set of problems, and how that can lead us to be seduced by this technology. POCUS changes everything. It changes the way we approach diagnostic and disease alike. Take shock, for instance. You can no longer talk about undifferentiated shock. That simply doesn't exist anymore. And as POCUS is gaining more and more widespread acceptance, it is currently shifting from the hands of motivated, technology-eager early adopters to those of just about every clinician, trainee, and student entering the House of Medicine. And that might be problematic. Let's face it. Most clinicians just want to be good. They don't want to be exceptionally good in only one technique. Laparoscopic surgery went through the same shift in the 80s and 90s. And as the practice of laparoscopy became everyday work, and as it shifted from the hands of pioneers to those of just every surgeon, guess what happened? Patients started to complicate. And that had to be addressed, and that's a problem currently looming on point-of-care ultrasound. Now, compared to Fox's prime time in the 80s, in our digital age, we have way more means of learning. Isn't that exactly what SMAC is celebrating? The music will start. Now let me show you another definite danger of point-of-care ultrasound. In medicine, and many speakers yesterday touched on this, we have to determine the plausibility that a given diagnostic approach or treatment actually works. And we have to do that by using studies, consensus statements, and we rely on expertise. And as far as the expertise part goes, it gets pretty interesting. In the psychology literature, it's pretty well established that given a certain prestige, it's easier to convince people by stating completely incomprehensible facts. Now, I don't want to mean to say or imply that podcasts on ultrasound or that courses on ultrasound are completely incomprehensible. But as point-of-care ultrasound is exploring new and more esoteric fields, the content is getting more and more complex. And that's kind of healthy. That's how science advances as a whole. But compounding this is the fact that we live in a world in full acceleration where knowledge translation times are just dropping, namely through social media, through FOMED, through podcasts. And while that is often a good thing, the problem can arise when good clinicians that have average, not excellent knowledge in ultrasound try to pick all that stuff up. Is it really realistic to think that someone who listens to a podcast can actually use Doppler like Fox or Malin? When we address that big mass of clinicians, we have to not only convey a sense of test characteristics like specificity and sensitivity, but also to realize that we don't live in an ideal world. We live in a world where humans impact the way we use technology. So we have to make sure we transmit how ultrasound should be used in the trenches day in and day out. And when people try to learn ultrasound, it's extremely important to realize that understanding how it should use or the concept behind is not at all the same thing as actually using it. I understand the concept of playing violin, but that's the last thing you want me to do on this stage right now. If we forget about these things, it's pretty easy to be hypnotized by the seductive side of ultrasound. Ultrasound is very, very narcissistically rewarding. Why do you think the Fox does it? We get to solve the puzzle. We're the masters of our technology. The patient isn't in undifferentiated shock anymore. He's in tamponade. And I'll drain it right now. We get to be heroes and make calls we didn't even dream of only 15 years ago. And that's a very powerful, very seductive thought that's kind of hard to resist. But if I'm able to see something, does it mean I should look for it all the time? If I'm able to see DVTs, is that the best use of my time, of the patient's time, of our global resources? After all, people of SMAC, it's not because you all own cars that you need to drive them to work every day. Next up is Chris Fox. I'm sure he's a very nuanced and sophisticated guy, but please, exercise some judgment and don't believe a word he says. Thank you.
Buy it, use it, break it, fix it, trash it, change it, mail, upgrade it, charge it, point it, zoom it, press it, snap it, work it, quick erase it, write it, cut it, paste it, save it, load it, check it, quick rewrite it, plug it, play it, burn it, rip it, drag it, drop it, zip unzip it, lock it, fill it, call it, find it, view it, code it, jump and lock it, surf it, scroll it, pose it, click it, cross it, crack it, switch, update it, name it, read it, tune it, print it, scan it, send it, fax, rename it, touch it, ring it, pay it, watch it, turn it, leave it, stop, format it. Technologic.
That concludes my presentation. Thank you very much. We're going to have some more fun, guys. First of all, it's been said that Canada is America's hat, and Maxime here would say that America is really Canada's shorts, okay? Canada's shorts. And you can see here, we're going to keep this PG-13, and Florida's not going to stick its little nose out in the audience, too, so don't you worry there. Maxime himself calls himself a fraud, that he does a lot of ultrasound himself. In fact, it wasn't even earlier this month. He was running a conference in Quebec on Hocus Pocus, ER ultrasound, and then even coming up here in beautiful Lubbock, Texas, is the World Congress of Ultrasound and Medical Education. You can see here, he is on the bill. And he's really involved with the Ultrasound Leadership Academy. This is him and his sidekick here, Jean-François, with their course, the EGLS course. And yes, thank you, everybody, Jean-François, everybody. And this is, in fact, he's even got a book. He's got a friggin' book on ultrasound, and he's up here. This is it, little plug for you there. Him and Jean-François. And they're even going to host the World Congress of Ultrasound Medical Education coming up next year in Montreal. So, where does that leave us? He tells you that I am seductive. He said it himself. And it actually has been published in the literature. This is an actual article. Okay, ladies, eyes up here, all right? This is in 1972. This article was published, the Dr. Fox Seductive Education. And you can see here from the top of the screen there that no matter what my content is, even here it is published in 1973 in Medical Education, whether when I was 3 years old, whether it's a low content, medium, or high content, my rating scores are much higher because of my seductive technique. And certainly, you know, do I seem interested in the subject? Am I using enough examples, which you're about to see, to clarify my material? Am I organized? Am I stimulating your thinking? And importantly, am I overstating or dwelling upon the obvious? And certainly when it comes to my passion for ultrasound and medical education and POCUS in general, I tend to dwell upon the obvious a little bit. So this is where I think ultrasound really comes into play. Of course, our work is never over. I love Daft Punk and how they do this. You know, do you need all this evidence out there to support the practice of ultrasound? Of course, we're all evidence-based thinking, but I mean, look at bats and dolphins and whales. They've been using ultrasound for years to locate their prey. And finally, in 1965, here on the cover of Life magazine, humans finally figured out how to use ultrasound here. Now, those early machines, of course, an oscilloscope hooked up to that water bath technique. I'm not sure that would make us faster, better, stronger, but luckily the ultrasound companies jumped in, and these went from big, giant, expensive behemoths all the way down to a handheld device that you could rent on a monthly basis with no contract. I mean, that's pretty impressive how that little device now, I think, really does make me better, faster, and stronger. Now, if you look at the other way to image the body, it involves, you know, some radiation there. One abdominal pelvic CT scan is almost 1,000 x-rays worth of radiation. So, you know, should we be punishing our patients with radiation, to steal a line from Mike and Matt? Or are we trying to use ultrasound first at the bedside to make us better, faster, stronger? Now, ultrasound is definitely harder. It's harder to learn the skills of POCUS, and I don't expect everybody to become a guru in it. But even getting the basic skills, as you're about to see, I think will make you better, stronger, and faster. Now, in the United States, we have a very complicated healthcare system. This is an actual slide from a United States governmental website of our healthcare structure. And you can see, it's funny. I thought it was fake at first, but the patients are over here, and I should say the physicians are over here, and the patients are over here. How do I migrate this complicated thing at the bedside with my patients in the emergency department? Well, I've got this little tool that I think closes that gap quite well and allows me to take better care of my patients, spend a little bit more time with them, and the images that are coming out of that machine, I'm putting them on the screen and showing them their pathology right there at the bedside. Now, how are we going to solve this problem in healthcare? And how does ultrasound solve the problem in healthcare, at least in the United States? Well, that may sound like a funny concept, but when you look at healthcare reform moving forward, up to 2020, which is they're really going to try to do a 25% cost reduction. Yeah, there'll be some scale, some integration, some operational improvements, but it's really going to come from a clinical re-engineering, changing what we do at the bedside to take care of our patients. And I really think there that while ultrasound may be a little harder to do than some of the other imaging modalities, it's definitely, I think, going to clinically re-engineer what we do and make us better, faster, and stronger. Now, no critical care conference would be complete without the Frank Starling curve staring back at you here. And what we're trying to do here is get a little preload to maximize our stroke volume, as you guys know. And so I'm just going to show you some examples of how ultrasound can be helpful there. This was a 90-year-old female that came in with urosepsis, and her blood pressure was low, and the nurses, we'd already given her a liter of fluid, and nurses were telling me her blood pressure is still low. I said, well, we might need to give some more fluids, and they were reluctant to do so in this frail little old 90-year-old woman with urosepsis. So we went to the bedside, and I explained to the nurse that, as the patient's breathing in, that's their IVC collapsing down, and they are likely fluid responsive. And indeed, after 2 more liters of fluid, the IVC finally plumped out, and the patient's blood pressure improved. What if the patient was, intubated on a vent, paralyzed? We could do the same thing. Getting into that apical fifth chamber, roll the patient a little bit. It's a little bit hard to do, I will concede that. However, you roll them on their side a little, you get into that apical fifth chamber, and you drop some pulse wave Doppler on there, and the fluid responders, if they have more than a 13% change between V peak max and V peak min, then those are the ones we're looking for, so we don't even need to get them to take a voluntary breath in that situation. The Italians have done an amazing job with lung ultrasound, and both these studies are wonderful. If you were to, put my hand behind my back, not let me use ultrasound for 1 hour, and compare me to the group that got to use ultrasound right away, the people that had to wait for an hour, they had a coin toss chance of making the diagnosis of pulmonary edema, whereas the folks who got the ultrasound got it right 95% of the time. Lots of literature there. I'm not going to bore you guys with that. But we do want to have some. When you see something on the television screen, it is just so compelling, okay? And you would have to agree. You look at this image, the patient's throwing up, Maxime, you're looking at this image, you're like, all right, this patient's got a small bowel obstruction. That's pretty obvious. It's shooting fish out of a barrel here. Woman comes in with vaginal bleeding and first trimester pregnancy, and you actually see the site of the blood pumping from the ruptured blood vessel there, swirling around in a pelvis. You got the diagnosis. It's right there on the television. Somebody with a swollen leg, you go to compress their popliteal fossa. It's right there. That's non-compressible. Save a clip and start the therapy. You get a patient coming in with right lower quadrant pain. You look straight at the television, it rules the nation. Your appendicitis is seen here with that periappendiceal, hyperinflamed fat around it and the loss of the layers, non-compressible tubular structure. This is so compelling when we see these images. My nurses use it to put in difficult to stick peripheral lines. We've reduced drastically our central line approach just by visualizing on the television the ultrasound going in. Here's a patient whose heart is not functioning very well. Everybody in the room can see that. This is a very compelling video seen on the television at the point of care, watching the endotracheal tube go into the cords here with that comma tail coming out of the trachea. Very compelling there in the use of point of care ultrasound. It's on the television after all. You said that ultrasound maybe there's some esoteric uses of it. Is it really for the masses? Are people really using the trenches? I think people are, and I think you could do it in a very simple way. This was a 16-year-old female that had eluded 2 pediatric pulmonologists for 4 months. She was having syncopal episodes. She came into our emergency department, and somebody just thought to put the ultrasound probe on her, first looking for a pericardial effusion, then they went down and looked at her IVC and saw that big mass there in the IVC. This is a large thrombus sitting in her IVC. You throw some color on there, outlines the filling defect. Everybody in the room can see it. We start the appropriate therapy. This was a video FaceTime to me yesterday while I was here in Dublin. One of my physicians was working in a remote access hospital in Catalina off of California. And she's like, this 80-year-old guy just came in. He's syncopized. He looks great right now. In fact, she turned the camera to the guy. He's like, hi. And then she looked back at the screen, and she's like, this looks like a gigantic AAA. I said, yeah, this is an 8-centimeter AAA. Immediately redirecting the care. This is somebody working in the trenches, the average, rank and file emergency physician, if you will, out in a critical access hospital. Now, blunt traumatic full arrest, we all know, horrible survival rate. I think with point-of-care ultrasound, you almost don't even need to classify it as penetrating or blunt anymore. Find the cause of the patient's trauma. This is a patient who has no pulse. Are they dead? Are they dead yet? No, the heart's moving. This is a survivable cause in even somebody who has blunt traumatic full arrest. I mean, even John Travolta can tell you that this patient's got pericardial tamponade. So usually I make everybody get up and do that, but I think I'm running short on time here. But you can see the RA and the RV dancing back and forth. That's that paradoxical RV collapse. It's so well demonstrated. But John Travolta, he's the kind of guy that stays up late to get lucky, right? Kind of what we do in emergency medicine. And I feel like we really have come too far to give up who we are. And we need to get back to the bedside, spend more time with our patients, raise the bar, and our probes to the stars. So with that being said, let's raise our hands in solidarity with the ultrasound revolution, you guys.
We're up all night to the sun. We're up all night to get some. We're up all night for good fun. We're up all night to get lucky. We're up all night to get lucky. We're up all night to get lucky. We're up all night to get lucky.
Wait, still
What
going.
a guru. Thank you, Riza, but I'll finish. Well, he was talking about all these amazing anecdotes, and I especially like the one where you say you put the probe in the patient's stomach to see if he's throwing up. I was actually looking on my phone. And that's a great one for the archives. I looked up on my phone, Chris Fox, erotic, and you can do that if you want. And this is actually what I found. It does look kind of weird amongst my other ultrasound books, but hey, that's Chris Fox for you. And I think I understood what he said. I think he said that ultrasound is good at giving us more data, like the IVC collapses 11.05%, or what was it, that VTI varies 31.2%. We can see small consolidations. But we have to make sure that that data actually correlates to clinically relevant information. We have to make sure it actually tells us something we didn't know before we looked with ultrasound, something that will change our management. Now, this pneumonia would be slightly more obvious if it was kind of playing, wasn't even visible in chest X-ray. That's a significant find. But what do we do if we see a patient who has a runny nose since the morning? That guy has the flu. And if we see a microconsolidation, should we call it a pneumonia and treat it as such? Ultrasound, if we're not careful, can definitely lead us to overdiagnosis, especially if we use the finding it gives us, the data we get from it, and apply it to our old ways of diagnosing things. Now, there's a mess up with my clips. I'll just change this for a second. And let's never forget that the history of medicine is filled with very, very popular ideas that have turned out to be gods with feet of clay. And as POCUS is maturing and exploring new and more esoteric fields, we have to make sure that we stay critical and that we think about this as a community if we want it to grow better and stronger in the midst of its own revolution. Thank you, everyone. Good job.
You done? Okay. Excellent job, guys. Michelle, what can you share with us?
The overwhelming sentiment from the audience was that this did not start out as a fair fight.
Didn't.
There was great respect for the line that you threw out, Maxime, at the end, messing with our version of reality, telling us not to believe a word he said, and I think that influenced people. But then it's the whole Twitter thing just deteriorated into a lot of analogies about boxing. There were a lot of flurry of punches and you being up on the ropes, and the ref was asked to come in and stop the fight before you had a head injury. I think the problem here was that Chris was preaching to the converted. Before we started, we have, yes, it's a problem, 25%, no, 75%. And the numbers, I'm afraid to say, didn't change terribly much, perhaps a little way in the opposite direction. So, Maxime, you were the clear loser. Sorry. Well done, Chris, you won.
Round of applause.